Yes. Hey. Couldn't get any internet down there, so they sent me down here. So I have some internet. Hmm.
Hello? Hello, for those of you that are joining us, we'll be getting started in just a few minutes. If you could go ahead and introduce yourselves via the chat, just scroll down and select everyone so we can get acquainted in this way. Thank you.
Hi,
Hello, Dr. Payne. How are you doing today?
I'm doing great. How are you today?
Awesome. Very good. We've got some people sign on, and it looks like we're almost to our time, so I might just go ahead and get started. I'll just introduce BHIPP and make a few announcements and then send it over to you. And as you'll see, some people are introducing themselves via the chat, so you can see who's here in that way.
Cool.
So welcome to those of you that are joining us. We'll get started in just a few minutes. Please do introduce yourselves in the chat by selecting everyone. My name is Rebecca Farrow. I'm a part of the BHIPP team. I will be introducing our presenter for today and facilitating our Q&A at the end of the session. And following today's session, there will be time for questions, so please do enter these into the chat. For those of you that are unfamiliar with BHIPP, I would like to provide some information about our program. Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination and training, and educational opportunities. The BHIPP warm line is staffed by a team of child mental health specialists and is available Monday through Friday, 9 a.m. to 5 p.m. Our phone number and website will be placed for you in the chat. And if you are already familiar with BHIPP and using our services, we encourage you to provide feedback in the annual HRSA surveys. You may be getting these through email, but we're going to provide the link in the chat as well. Your feedback on these surveys is important in supporting the program's goal to increase access to behavioral health services in Maryland, and it will ensure programs like ours continue to support health providers in addressing behavioral health in the future. So that link will be in the chat. And it is my pleasure to introduce today's BHIPP Resilience Break, Disruptive Behavior and DMDD, presented by Dr. Robert Payne. Dr. Payne was born and raised in Baltimore, Maryland. He received his BS in chemistry and psychology with honors in general education from Frostburg State University in 2005. I would just like to make a note real quick. I'm hearing some audio feedback, so if you could mute yourselves, that would be appreciated. So following graduation, Dr. Payne worked as a mental health worker on the children's inpatient unit at Shepherd and Enoch Pratt Hospital. He then completed his medical education at the West Virginia School of Osteopathic Medicine in 2011, his adult psychiatry residency at the Charleston Area Medical Center, West Virginia University Charleston Division in 2014, and his child psychiatry fellowship at University of Maryland Shepherd Pratt in 2016. Upon completion of his training, Dr. Payne stayed at the University of Maryland, Baltimore as an assistant professor in the Department of Psychiatry. He is the child psychiatrist for the UMMC Child Psychiatry Council and Liaison Service, provides telepsychiatry services for the Maryland Department of Juvenile Services, and supervises trainees in the ADHD and mood disorder clinics. His areas of interest include developmental trauma, attachment disorders, complex psychopharmacology, psychodynamic psychotherapy, positive psychiatry, and mentalization-based psychotherapy. And he is also a consultant for us here at BHIPP. So we are very grateful to have you here today, Dr. Payne. Thank you for sharing your expertise with us during the session. I'm going to hand it over to you.
Thank you for that lovely introduction and for having me today for this resilience break. I'm going to go ahead and share my screen. That's how I'm supposed to share these slides, right? Yeah, okay.
Yep. Yeah, I'll let you know if we can see them clearly.
Okay.
Yep, looks great.
All right, so we will be talking about disruptive behavior and disruptive mood dysregulation disorder. I have no financial relationship to disclose. Our objectives for this talk are to understand the behavioral perspective of psychiatric illness and pathological behaviors, apply the theoretical perspectives discussed to develop a differential diagnosis for disruptive behavior disorders and DMDD, and to understand the evidence-based treatments for disruptive behavior disorders and DMDD. So, sorry, I was just trying to toggle my screen. Okay, we're good. So first, the first thing we'll talk about is the behavior perspective, which includes driven and motivated behaviors and socially learned behaviors. We will then review a disruptive behavior case formulation with an overview of assessment, diagnosis, and treatment planning. Then talk about treatments, which include therapy, medication, and then have time for questions and comments. So the behavior perspective is a way of looking at psychiatric illness.
The booster one comes available for him, even though
this is outlined in the Perspectives of Psychiatry, which is a Johns Hopkins publication. They define the term behavior.
I know they're not giving him to.
I'm sorry, okay. Were you saying something?
I just want to remind everyone, if you could please mute yourself so that we can hear the presenter. Thank you.
Yeah, so so the term behavior applies to any motor sensory activity linked to a goal. Learning plays a role in all behaviors. Behaviors can be classified as driven or socially learned. So driven behaviors are driven and satiated by physiological mechanisms. Driven behaviors are vital organismic needs. So this would include sex and reproduction, drinking and eating, sleeping, and maternity. The triad of driven behaviors includes conditioned learning, physiological drive, and choice. So when we look at treatment targets in the driven behavior perspective, in addiction, the 12-step absence for today is, focusing on the aspect of choice, simply choosing to not engage in that behavior. The physiological drive, so this is medication-assisted treatment, methadone, Suboxone, and in paraphilias, they use anti-androgen medications to dampen the physiological drive for deviant sexual interest in sex offenders. Conditioned learning, this is antabuse or disulfiram is the generic for alcohol use disorder and contingency management. On the other hand, goal-directed behaviors are primarily shaped through social learning by interaction of antecedents, responses, and consequences. Personal choice becomes enmeshed with social influences. So this is the triad of goal-directed behaviors. Antecedents have predisposing, precipitating features. Responses have choice, action features. Consequences have reinforcing, sustaining features. Learning's path occurs across this trajectory. Disordered aspects of behavior may be defined by maladaptive goals, means, consequences, or provocation. within this framework, we can consider disruptive behavior disorders as well as full refusal behavior. So when we do a behavioral assessment, we have two different questions. What is going on and why? So a detailed way of looking at what is going on is called a functional behavioral analysis. This typically involves a caregiver report and observation in naturalistic settings, school and home typically with children and adolescents, to determine what is the antecedent trigger of the problem behavior and what are the environmental responses or consequences maintaining the behavior. Patterns of antecedent consequence help to identify the problem behavior's function. So in collaborative problem solving, we ask why. So challenging behavior occurs when the demands being placed upon a child outstrips the skills they have to respond adaptively to those demands. So within this way of thinking, one of the core assumptions is children prefer to do well, and doing well is preferable than to not doing well. And I think that's it seems so simple to that it doesn't even bear mentioning, but sometimes caregivers will be so frustrated and demoralized by the child's behavior that they believe that the child is doing this and they enjoy doing this. So to kind of shift the thinking to like the kid would rather not be doing this, or they're doing this for a specific reason. So when we are able to think of things this way, and we can identify the conditions that precipitate challenging episodes, we can then predict when these things are going to happen, so we can kind of work on, preventing them, or at least making them more manageable instead of being overwhelmed by the seeming randomness of it. Also, within this perspective, the family and the interactions of the family is the target of the intervention, as opposed to focusing on just the child as the identified patient. So within behavioral therapy, the process starts with assessment and psychoeducation, focusing on prevention strategies as we understand more about predictably when these things happen, consequences, generalization, and maintenance. So these are some great books. For parents, I typically recommend The Explosive Child by Ross Green. He also wrote this book, Treating Explosive Kids. I provided an outline of these concepts in a supplement I think was provided along with this. If you don't have access to that, please let me know at the end, and I'll be sure to give you a copy of that. I have this book in my office because it is so good. And while this might be out of the primary care provider's scope of practice, I think it's certainly helpful to sort of know what the core concepts are to sort of know like how we would think about these things and the most helpful ways to approach these problems. So shifting gears here a little bit to the DSM-5 category of disruptive impulse control and conduct disorders, which are psychiatric conditions involving problems in emotional and behavioral regulation. These are disorders differentiated by predominant impairment in emotional and behavioral dysregulation. So on one end of the spectrum, we have conduct disorder, which is primarily behavioral dysregulation. Its prevalence is approximately 4%. On the other end of the spectrum, predominant emotional dysregulation with intermittent explosive disorder, relatively more rare than the other two, prevalence of 2.7%. In the middle is oppositional defiance disorder, which includes behavioral and emotional dysregulation. Its prevalence is 3.3%. So we're going to discuss a case. Max is a 14-year-old male seen in the emergency department accompanied by his parents after becoming very aggressive with them. He punched a wall and vandalized his room after his parents grounded him because of his previous defiant behavior. He has been suspended from school that day for disrespecting his teacher after he was caught fighting another student. His parents described Max as a strong-willed, stubborn child. He has difficulty with rules and refuses to follow them. He is grouchy and irritable around adults, including the emergency department staff. Max enjoys being with his friends and playing video games. He had been diagnosed with ADHD when he was in kindergarten, when his teacher noticed he had a poor attention span and couldn't sit still. According to his parents, Max has blown up a few times before, smashing items in his room and shouting obscenities. Parents notice that he is more defiant in concurrence with discontinuing his ADHD stimulant medication. So, an overview of disruptive mood dysregulation disorder. This is a childhood condition of chronic extreme irritability, anger, and frequent intense anger outbursts. It is characterized as a depressive disorder in DSM-5, reflecting longitudinal findings that children with chronic irritability typically develop unipolar depressive disorders rather than bipolar disorders in adulthood. So a mnemonic that's useful for remembering what the DMDD DSM criteria are is OIVE. So outbursts for O, frequent impairing in more than one place, which is important because it would, this being a chronic across multiple settings reflects how pervasive this illness is. So it can't just be a conflict with a specific parent or a teacher. So they have irritable mood when not having outbursts. This is a key differentiating feature when you consider whether it's DMDD versus something else. They have irritability between outbursts. They're always irritable, grouchy, angry, and that differentiates it from other conditions. This is a very chronic condition. It has lasted at least a year. It's not better explained by another better understood condition, such as mania, major depressive disorder, post-traumatic stress disorder, anxiety, autism. These are more well studied, more well defined, and they are ruled out conditions for DMDD. This illness starts in early childhood, so before age 10 is required. So if this symptom presentation starts after 10, it's not DMDD. It has to be before age 6 after age 6 and before age 10.
Mm-hmm.
So really the point of this slide is to show that in studies that look at irritable and explosive kids, this is the sample size at the top here. It's really showing that the comorbidity with ADHD and oppositional defiant disorder is very, very high. So what is Max's diagnosis? And I know we don't have like a way to participate. The answer is, I'm sorry, go ahead.
I was going to say we could have people enter into the chat.
Sure, that would be fun. Let's do that.
If you want to enter the letter A, B, C, D, or E into the chat of what diagnosis you think for Max. We have a few E's, a B, someone torn between D and E. More E's coming in. Lots of E's.
Awesome. So E is what we're thinking, ODD plus ADHD. And while we were doing the survey, I was messing with my screen, and I think I outsmarted myself, moving myself around the screen here. Okay. So when we look at a differential diagnosis of explosive outbursts, first we want to look at whether they are rare or if they are frequent. So if they're rare, then it's not likely to be DMDD or bipolar disorder. If they are frequent, we want to then see whether this is an acute change from their baseline behavior or self. And then we can look at the age of the child. So pre-pubertal child you're going to more likely see a acute stressor to explain what is going on. So it could be either home, family problems, they're possibly a victim of abuse, or at school, they could have some undiagnosed or not recognized yet learning disorders, or they're experiencing bullying. If they're a teen, mood disorders become more prevalent after puberty. So you want to first rule out a mood disorder such as depression, bipolar mania, anxiety disorders, substance use, and psychosis. Now, if they're chronic, we are now looking at a kid that's either irritable tween outbursts, as I said before, this is DMDD, which is actually relatively rare. A lot of the kids that we see are typically very pleasant and likable in between these periods of frustration. But when there's a limit set and they don't get something that they really want, or they're frustrated by something, that's what we say fine until frustrated. And this is the ADHD and oppositional defiant disorder combination. So when we look at treatment planning, our goal is to reduce the frequency, intensity, and duration of explosive episodes. So what I tell my fellows and residents is the acronym is FIND. So it's frequency, intensity, number, and duration of explosive outbursts. So we want to first start with behavioral therapy as a first-line intervention. When we look at practice parameters, expert consensus recommendations, behavioral therapy, as well as psychoeducation is considered a first-line intervention across the board. And this should be implemented across all settings. And then medication treatment should target common comorbid disorders, ADHD, depression, anxiety, the big three. So a systematic approach to mood dysregulation, doing a comprehensive psychiatric assessment. So while ADHD and ODD are common, anxiety, depression, and autism are other common primary disorders, and this is why they're rollout for DMDD. And as I said before, keep careful records of its frequency, intensity, number, and duration of outbursts. And number two, maximize the treatment of the base condition. Most data is ADHD combined type. If symptoms remain, or if you have residual symptoms, you can add another medication. So if you have an anxiety or mood disorder picture, you could use an SSRI or an SNRI. This mixed receptor antagonist is another name. They call it neuroscience-based nomenclature for atypical antipsychotics. And they are moving this direction because, so we already do this with alpha agonists. It's a neuroscience-based nomenclature name. And because we're not using the medication for psychosis, and when we say antipsychotic, it usually raises some eyebrows, if not, a lot of concerns, rightfully so for the parents. But this is kind of the direction our field is moving in. So I have this in here in quotes, but this is another name for atypical antipsychotics. Mood stabilizers, and for either, antipsychotics or mood stabilizers, weight gain can respond well to metformin if you use it relatively early in treatment. So it's something to pay attention to early, because if you wait a little too long, it can be hard to reverse the weight gain. It's also, unfortunately, a quite chronic condition. These kids can remain impaired and need a lot of pretty intensive multidisciplinary help, and short-term solutions are often inadequate. So I think it's helpful to think about that when you manage your expectations for the family as well. So when we do pharmacotherapy, we try to measure target symptoms the best we can. So two components to that is how the child feels, which for depression and irritability, we have the CESDC. For younger kids, the PHQ-9 for teens. I typically recommend this scale in children ages 12 and above. And we also have the SCARED for younger kids, and the GAD-7, more specific for generalized anxiety disorder. SCARED gives you a better, a broader symptom assessment for anxiety. And then what the child does, modified overt aggression scale, as well as the parent and teacher Vanderbilt. If you're targeting aggression specifically, it's helpful to get the modified overt aggression scale because it has questions about verbal aggression, and it has a like a graded approach. So shouting, profanity is like a 1, and then like, multiple insults, screaming, yelling, cursing people out for numerous minutes at a time, that's a lot more verbal aggression. So for pharmacotherapy, the first point is that we don't unfortunately have any medication, for DMDD. DMDD is relatively new. It was first introduced in the DSM-5, which was published in 2013. And there has been some effort to identify helpful medications for DMDD, but it's still really hard to study, and it's been a slow-going process. But we do have other options. So we first recommend really focusing on and optimizing treatment for ADHD, which would include stimulants, alpha-2 agonists, and atomoxetine. Antipsychotics have data as well. Mood stabilizers, including divalproex or Depakote and lithium, and antidepressants. So stimulants is typically a first-line option and is most likely to give you your best bang for your buck, and it's also relatively safe and well tolerated. So emotional dysregulation commonly occurs in youth with ADHD. As I said, optimization of CNS stimulant therapy of ADHD is well tolerated and effective for externalizing symptoms, irritability, and parent-related impairment or parent-rated impairment. CNS stimulants should be considered as first-line pharmacotherapy for DMDD, particularly for patients with comorbid ADHD. So for alpha-2 agonists, we have data to support both ADHD monotherapy. It's helpful to know that this effect size is less robust than stimulants, but may be offered if patient family objects to stimulant treatment. We can use guanfacine ER. It's important, or this is intuitive, this is important to target a 0.1 milligram per kilogram per day dose range because sometimes it's given up on a little bit too quickly, and it's actually in the package insert. If you search on Hippocrates, it gives you a weight-based dosing, depending on how big the kid needs. You can dose it up to 7 milligrams a day. We also have data for stimulant partial responders. So 25 to 30% of ADHD patients fail to respond to stimulant monotherapy. Useful in afternoon for rebound, impulsivity, hyperactivity, emotional dysregulation after stimulant wears off. So I often use this clinically in the early afternoon for patients that, as they transition from school to home, they're having a lot of issues with those rebound ADHD symptoms. Obviously, it's difficult to give them, a stimulant in the early afternoon because of problems with their sleep, number one, and their appetite as well. So this is usually a very effective and well-tolerated approach to kind of target those symptoms as the stimulant wears off. Atomoxetine, in my personal opinion, I find that it's underutilized. It's typically a second-line agent for patients who cannot tolerate or fail to respond to stimulant treatment. Similarly, it's not as robust as stimulants. It does take a little bit longer to work, but for the right patient, if dosed appropriately and given enough time, it could be very helpful. So a randomized controlled trial showed significant improvement in ADHD and ODD symptom domains compared to placebo after 9 weeks of treatment. So I think it's important during the the informed consent process to kind of tell families this might take a little while, but if we kind of need to if we're gonna try this, we got to give it some time. So this is important to remember. We can initiate it at 0.5 mg per kg per day, increase to 1.2 mg per kg per day after 3 days. We can use BID dosing to mitigate tolerability concerns at higher doses. So I've had success with this approach. and I've never had any problem with insurance approving it. But depending on what payer you're using, it could require prior authorization, but it shouldn't be much of an issue. So antipsychotics, if the use fails to make treatment gains with the agent best suited for his or her primary disorder, the physician should consider adding an atypical antipsychotic to the primary treatment. So that's like kind of the overall message is it's best used as a second line add-on after you've tried behavioral therapy, parent training, and ADHD treatment. Then you kind of add this on if you're not making sufficient progress, or the kid is just like so aggressive that they're like really dangerous for themselves and others. So this is the treatment of severe childhood aggression style or trial, evaluated the superiority of 6 weeks of parent training plus a stimulant plus risperidone over parent training plus stimulant plus placebo. So everyone got parent training, everyone got optimized stimulant treatment. I think they used Concerta, and then they randomized the groups to either risperidone or placebo. And children 6 to 12 years old with ADHD and severe aggression. So, like I said, they kind of ramped up over the 9 weeks. They did 3 weeks of parent training and stimulant treatment first, and then they did the randomization over 6 weeks. So if they didn't respond to either parent, so some kids actually did fairly well with the parent training and stimulant combination. So the kids that were refractory to that first line approach then were randomized to the risperidone or placebo. So there was medium advantage of augmented over basic treatment on the primary measure of disruptive behavior. So for divalproex, a randomized controlled trial found that when treated with stimulant and divalproex adjunctive treatment, 30 use of ADHD and chronic aggression, refractory to stimulant monotherapy demonstrated higher rates of remission of aggressive behavior. This data isn't as strong, obviously a very small sample size, but there is at least some data supporting its use. Lithium, earlier studies found that lithium significantly improves aggressive behavior in hospitalized pediatric patients with conduct disorder. A later study comparing lithium versus placebo to treatment of severe mood dysregulation found no significant difference between groups. So its results are mixed. It's also very difficult to use lithium. Youth who present with severe irritability aggression to be screened for depression and anxiety disorders. If criteria for either of these disorders are met, the clinician may consider a trial of SSRI medication indicated for that disorder. We have reached the end. So we talked about our program, and I'm very excited to be part of this phenomenal effort. So it's free, so that's always a great point. And I think a lot of you are already very integrated and involved in BHIPP, so obviously you're here for that reason. And we have, the program is just rapidly growing since I first became involved in 2017. Thank you all for your attention today.
Thank you, Dr. Payne. That was a wonderful presentation, and we'll have time for questions now. We do have one already in the chat that we'll start with, but again, if others want to enter those questions, we'll answer those now. So the first one here, Dr. Payne, can you review scoring for the MOAS?
Sure, let me see if I can actually share that with the group. I do think it is quite important.
Yeah, that would be great. While Dr. Payne's pulling that up, I will just mention the full recording for today's session, a resource handout that Dr. Payne created, and your CME, CE certificates will be sent by the end of this week. And those resources will also be posted on our website, and we'll put that link in there so you can keep an eye out for those. Oh, and I don't know if I mentioned the slides, but those will be coming to you too.
Okay. So, and you see the scale here.
Yep.
Great. Well, I love how it's you know, it's relatively straightforward. You know, for scoring, it you know, it kind of just says use the score to track changes in level of aggression over time. So I find it helpful when I think about this, and the way I use it clinically is, you know, first and foremost, you know, I want to make sure that the kid is not being physically aggressive and putting themselves and other people at risk. That's usually my first treatment target, as well as kids who, you know, when they're super dysregulated, they might bang their head or punch themselves or do something else, this autoaggression. So I like that that's part of the scale as well. Now, you know, I really want to try to get this. I want to try to make a significant improvement in these symptoms, particularly physical aggression. If we have to start somewhere, and you know, so that would be, I think that's a good way to think about it, as well as to kind of the way that it talks about no aggression against property being a 0, slams door, rips closing. Thankfully, I don't see kids urinating on the floor too much, but it does happen, I suppose. And you know, if this happens, families might become demoralized and very upset. So if you're able to say, look, you know, like he used to, you know, break everything in the house, smash their TV, smash the windows. Now he's just like slamming a door. He might have punched a hole in the wall, but it's actually improving. So you can kind of, it helps to keep track of these things as you know, continue to work with the family so that they don't get, you know, so demoralized that they want to give up. And just like, you know, make major changes or just say like this medicine's not working, we need to try something else, we need to increase the dose. So I think this is helpful to sort of organize your thinking and also to gather this data the best you can. And again, with the verbal aggression, you know, making personal insult, severely insulting, and then threatening violence verbally is the higher end of the scale. And then at the bottom, it has like a sum score. They actually have weights. So you do like a weighted sum, like I said, physical aggression, autoaggression are both weighted more heavily because they're more clinically severe symptoms that are, you know, safety risks. And maybe we can share this one also with, I mean, it's in the public domain. This is I think within the primary care toolkit, but we can also share this one as well.
Yeah, certainly. Thank you for that question.
Yeah, it's a good one.
So we have another question here. In your experience, how long do kids have to stay on these medications? Are they something that could be long-term into adulthood?
What a great question. Yeah, so in my experience, we often, you know, get this question a lot. Families will ask, like, does he have to take this forever? And I'll say, you know, I really can't tell you how long it's gonna, like, how long they'll remain on this. For risperidone, I was just reviewing in this book I have that they have data to support its use for up to 2 years. When they did long-term follow-up study on TOSCA, about 50% of the kids that were randomized to placebo actually continued to do well. So after about 6 months, they questioned whether it's worth considering taking the kid off of the medication to see if they can do well without it. In theory, as some of the therapeutic interventions work with the families, if you're able to make some progress in the comprehensive picture, in theory, you know, they might not need the medication longer than that. So it's worth considering deprescribing it after about 6 months or so. But, you know, it is for some kids that are in, you know, child psychiatry care, you know, they might need it a bit longer, but at least for ADHD, I think we do see that kids tend to do best if they're on the medicine longer term. A lot of the impairments do, you know, gradually improve as, you know, the brain matures and, their frontal lobe continues to come online, maybe until they're about 25 years old. I think that's what, when the frontal lobe is fully mature. Coincidentally, I think that's when like our car insurance rates go down. So that's, but that's kind of what we counsel families. But it's generally like a wait and see approach.
All right, thank you for answering that one. Another question here, what if a patient refuses mood stabilizers?
Yeah, I think we have to meet people where they are, and that's why I tend to prefer like the stimulant and ADHD that route first, because oftentimes the mood stabilizers can be more they do have more risks, and they also are scary to take, and people don't typically like to take them, and I think you have to start somewhere. Sometimes people will eventually capitulate, in my experience. Like after a while they'll say like, okay, like we have, like I don't know what else to do. So I think after a while sometimes people will change their mind, but if people refuse, then that's okay too. We just have to like see what they are willing to do and just go from there.
Great, thank you. So we have another one here. Could you review how to differentiate DMDD, conduct disorder, and ODD?
Yeah, that's a good question. So conduct disorder involves predatory, premeditated aggression. There's like a big difference in the literature. They talk about proactive aggression, which is cold, calculated, lack of emotion, psychopathic aggression. That's conduct disorder. And also in conduct disorder, there's typically, I call them hard symptoms. So this includes like fire setting, forced, sexual assault, things like that are just like really, really problematic. Those are more indicative, and as well as like cruelty to animals. Those things are more likely to be conduct disorder. On the other hand, kids that have reactive aggression, this is aggression that occurs, very impulsively and we call it hot aggression as opposed to cold aggression in conduct disorder. Hot aggression being more indicative of either DMDD or ODD plus ADHD. So these kids are more, this is thankfully, the large proportion of the kids that we treat are typically reactive aggression or hot aggression. And then you can kind of ask, as I talked about on the flow chart, is the kid irritable between outbursts? If they are, then it's DMDD. If they're not, it's probably ADHD plus ODD. We get these kids admitted to our inpatient service. I read the history that brought them in. I meet with them. They're very nice and appropriate on the unit, not really any major problems. That's pretty classic for like an ODD picture, as the kid is, then challenged a little bit more, is put in a situation where their ability to tolerate frustration is put to the test, and we might see some of the behaviors that brought them to the hospital come out. The kid that has DMDD is typically not very happy to meet with anyone, isn't very, you can see the irritability, and it's less common, but we do see it. But yeah, generally speaking, the kids we see are like the ODD and ADHD combination.
Great, thank you. Thank you for all these questions. These are really helpful and
Yeah.
nice to explore what you're interested in here. We have another one. I serve children with ASD and find that some may have baseline irritability along with behavioral outbursts. Do you ever diagnose DMDD with ASD?
So I think they're mutually exclusive conditions. So if the mood outbursts, the temper outbursts are thought to be, it's thought to be like core to the autism spectrum condition. So I think that's why it's a rule out, because again, because the impairments that autism presents with are going to be like the specific targets for intervention. along with possibly using risperidone or aripiprazole, which are both FDA approved for irritability in that condition. But I think it is something that it's like one of those DSM rules. Like, I don't think you can diagnose them together, is my understanding.
Okay, great. When a youth with DMDD diagnosis continues to have aggression when they turn 18, is DMDD diagnosis continued, or are other diagnoses considered?
That's another great question. I don't think they, and I'm not sure. I'm not sure if you continue to diagnose them with DMD. I guess you do, but man, this is a good one because I think it's like some of the kids that we've been diagnosing with DMDD since the manual is published, a lot of them have graduated to adulthood, but some of them haven't. They're still like kids, but I'll need to look into that a little bit more. But that is a really, really good question.
Thank you. And we have another one. I don't see the question exactly, but I believe it's been asked about parent training piece. If you could talk a little bit more about that.
Yeah, when I'm doing parent training with families, first, like, it's important to, there are a couple manuals. One of them is like the Incredible Years Parent Training Program. This opposition, like looking back through the slide deck, one of the books that has a, let me see if I have it in here, Barkley Parent Handout. I can also share these.
Sure, and I do have the full question now. So as a non-professional here and a parent with a child who has a diagnosis of ADHD, ODD, and most recently DMDD, do you have any specific suggestions for more aggressive care and the parent training?
Can you say that last part again for the aggressive?
Yeah, any specific suggestions for more aggressive care and the parent training?
Aggressive care and the parent training. So I'm gonna pull this up here. Okay, so this is from the Defiant Children Barkley manual, and it has like a bunch of forms. I'm going to skip ahead to, so with older kids, there's a bunch of parent handouts, and I also find a couple of those books helpful. I will also like think of a couple others that, since I first created this presentation, there's a couple others that I think might be helpful that we can share as well. First, I want to say I really appreciate this question. I'm so glad we have, parent involvement. This is great, and I'm not sure what has been tried, or what we can still do. But one of the things I like is for older kids, having like a really solid like token economy, this home poker chip point system. I've seen this work for kids. When, first of all, like if they're working towards something that's salient to them that they really want, I find that they can really improve with this program. So, the idea is that they earn chips and they can use them for a specific prize that motivates them. So, and again, I can share this. We can share these with the community. And this is an important part. Do not take chips away for misbehavior. So that's, kind of, the idea is that they're more likely to do well if they're able to kind of like accrue them, and we figure out a different way to manage consequences. But this is something that they can, and the idea is that we want to reinforce desired behavior with something that's motivating. I hope this is a helpful start to the answer to your question.
Sure, thank you. And just to clarify, I don't know if you have any other thoughts to add, but the parent is saying more in kind of intensive care, or different strategies, instead of the word aggressive, like more intensive treatment and care for this case with ADHD, ODD, and DMDD diagnoses.
Mm-hmm. So about like what treatment options, like including like are we asking for like a specific location or like a modality? Some of these kids require residential care, unfortunately. If you've tried lots of things as an outpatient and there's still a lot of needs and there's been insufficient progress, some of these kids will require like a residential therapeutic placement for like 6 months, maybe longer, you know, to really work on a lot of these things.
All right, well, thank you for answering those. I'm not seeing any more questions at the moment. We can hang on for a few minutes just in case we do have any more trickling in. You know, I might just ask while we're waiting, you know, these behaviors that we've reviewed can be very distressing for families. How might you work with a family who's just feeling really overwhelmed and frustrated with their child's behavior? What might you say to them?
Yeah, so that's a really great way to say it. Well, I will first, you know, say like, look, you know, I know this has got to be hard. I'm a parent myself, and I have, you know, and she's 2.5, and sometimes she's like, you know, it makes me feel very impatient and frustrated, and she's only 2.5, and I can only imagine like how this feels. But please rest assured that we know how to treat this, that we do have treatments that we've seen them work. So just offering hope, and giving them some reason to want to keep going, but to know that a lot of families come into us like feeling very exacerbated and at the end of their rope, so to speak, and to know that like we can fix this.
Yeah, that's great. Kind of creating that community as well of support and not being alone in the journey. I'm sure that's
Exactly.
cool.
Yeah. And that, you know, again, like the Explosive Child book is written for families, and I find that people have really enjoyed that approach. I've read some of it. It's like kind of, you know, the way that the book is written is specifically designed for families, and I find that people find it very reassuring and refreshing to kind of know that like not only do we like other people experience this, but we know what to do about it. It has this compassionate, you know, viewpoint and a wish to solve this problem together. It's called collaborative problem solving for that reason. And, you know, knowing that the child's not doing it on purpose, that they want to feel better, they want to behave better, and they simply are really struggling with certain specific areas.
Yeah, that's definitely good to keep in mind. And I think a good closing thought for us today, unless you had any other points that you'd like to add.
No, I've really enjoyed talking about this topic, and I really appreciate everyone's attention and interest. And please let me know if I could be helpful moving forward.
No,
Thank you for
Dr.
having me.
Payne. Yeah, we really appreciate this presentation today. And just for everyone, when you close the window out, you're going to get an evaluation survey, and we really do appreciate your responses there. And we'll send out your materials within the next 3 days. So thank you all for joining us today. Have a wonderful rest of your day.
Thank you, everyone. Have a great day.